link. Okay, evening everybody. I'm really sorry about all the teething problems that we've had. For those of you who I haven't met, my name is Janice Stradom. I'm the chairperson of HAE South Africa. I have been since the end of last year. I took over from Adrian de Jong. Adrian was instrumental in starting HAE South Africa in 2016, and she has now decided to get involved in some genetics exercises for the next couple of months. You've all met Tamsin now, I'm sure. Tamsin is our secretary. She's also the only board member of the four of us that doesn't actually have HAE. She's Adrian's daughter, so she was lucky enough not to have inherited it from her mom. MJ Darfel, who looks after our finances. And then Hannah Ford, who unfortunately had to resign from our board at the end of last year because she had moved on to another country. So she is still involved with HAE International Youth on their side. Just in terms of what we've done over the last year or so, you will have noticed that we have a new brand, we have a new logo, we've launched a new website. So if you could all please try to go and have a look at it. If you've got any, I'm sorry, is Janet? Okay, Janet's just going to come out and then, yeah. So if everybody can just take some time to go and have a look at our website. If anybody has any recommendations for us, anything that you'd like to see, please let us know. We've also worked very hard on our social media sites. So just to give you an indication on our Facebook, we currently have about 6,700 people a month. So we really are making a good headway in advocacy with HAE. For HAE Day, I think it was probably the busiest one that we've ever had. We started off in the week in the run up to HAE Day with a number of videos that we did. We also did about 8 or 9 live radio interviews, which Prof Levin and Prof Mike Prof Levin and Prof Jonny helped me with. A number of newspaper articles, and then we were also able to get what we've been trying to get for ages, which was some digital feature articles. There was one in the Drum magazine, there was one in the U magazine, and there was one in the Huisgenoot. From those, we had numerous requests from people, numerous patients who phoned and said, I think I might have this, or I think my sister might have this. So I think that probably about 1 in 15 of the patients that we end up sending for testing actually have HAE, so our patient organization is it may be growing quite slowly, but it is growing. But I think as an organization, if we can just help a handful of patients with diagnosis and with treatment and with emotional support, and then that is I'd like to thank them for what they've done to help us with the advocacy that we've done to make also to raise awareness of how important these patient organization groups. So I'm going to launch into introducing our speakers. We have Prof Mike Levin. Mike is the CEO of the Allergy Foundation. He has a special interest in HAE and looks after a number of our pediatric patients. Mike also runs numerous masterclasses for other doctors. As you know, there are not many doctors who actually know about HAE, so we really appreciate all the ones that we can get. Then Prof Jonny Peter, who heads up our A-Care Centre. For those of you who don't know, A-Care Centres are angioedema centres of reference and excellence. Prof Peter and his team look after not only HAE patients, but also angioedema patients in general, which makes a good partnership for us because the patients that come to us, of the 14 of the 15 that come to us who have angioedema but not necessarily HAE, are still able to be treated by his centre. So Prof Peter's done a lot of work towards getting new medications into the country for us. So he's going to chat to us tonight about those medications, how they work, which ones are best for us, and how we can access them. And then we have Marianne Gomes. Marianne is a genetic counsellor. She worked for a number of years, not only as a genetic counsellor, but also as a lecturer at Wits University, and she's now working full-time as a genetic counsellor for Rare Diseases South Africa. So I think, Mike, if we can kick off with you.
Thanks, Janice. Just confirming that you guys can hear me okay?
We can.
And that you can see my presentation now. Oopsie. Yep. Can you see the presentation properly?
No.
No, I can't see anything.
That's problematic.
Here we are.
There we go.
There we go.
All right, cool. So thanks, Janice, for the introduction. And I'm going to be talking about really the introductory parts about angioedema in general and about hereditary angioedema in particular. So urticaria and angioedema are both very common conditions. They often occur together, but they represent swelling into different sites of the skin. And importantly, they can be caused by very different conditions. Angioedema is these typical wheals that you can see that are raised, bumps, usually a little bit pale with a little bit of redness around them, and they tend to move around on the skin and last for less than 24 hours. But angioedema is swelling in the deep layers of the skin or the mucous membranes. It's usually painful and usually not itchy, and it lasts for much longer than urticaria lasts. Urticaria is caused by histamine, and when urticaria and angioedema occur together, histamine is also the cause of that particular combination. But isolated angioedema, where it occurs alone without any urticaria, is a completely different problem, usually caused by medications and by hereditary angioedema. And there's a completely different mediator that is responsible for the swelling called bradykinin. Angioedema affects different parts of the body. The most common thing that people know about is the swelling that occurs in different parts of the body that is usually asymmetrical. But it's also very important to remember that it can also occur in the larynx, which can cause airway problems and can be fatal. And it also occurs in the gut, causing massive abdominal pain. And this abdominal forms of angioedema are very, very important to recognize and treat, because you can't see the swelling until you only feel it when there's pain and it's very severe. So when we look at the different forms of angioedema that are caused by histamine on the left and bradykinin on the right, you can see that on the left-hand side, there's always the urticaria that's involved. There's a lot of itching. It comes on very quickly, and it responds to the medications that we would give somebody for a severe allergy attack, like adrenaline. And it can sometimes be associated with those other signs of a severe allergy attack, which is airway signs and cardiovascular signs. But bradykinin-mediated angioedema is quite different. It has more facial swelling, a much more focus on the abdominal pain, and there's this asymmetrical peripheral angioedema and swelling that is seen. One of the other big differences is the time course. So angioedema due to allergies, the histamine-mediated form that you can see in blue occurs quite quickly. It comes on very quickly, and then it goes away very quickly. And it always lasts for less than 12 hours. The angioedema that is caused by drugs usually lasts about 2 days, but hereditary angioedema is often much more prolonged. So some of the questions that we would ask patients who present with angioedema is, did they take any of the medication that is associated with triggering angioedema? How early did it start? Because hereditary angioedema often starts on earlier, clearly before any of those drugs are taken. Are there any abdominal attacks? Are there family members affected? Have there been any prodromes? And that's the itchiness that can occur in the area, or the tingling in the area of the swelling. And has there been any failure of treatment with the medications that is used for allergic type of angioedema, which is the antihistamines and the corticosteroids? So just a couple of words about drug-induced angioedema. There are two major classes of drugs that you can see that are involved in causing swelling. And these are the ACE inhibitors and the non-steroidal anti-inflammatory drugs. And you can see both of these drugs have effects on these pathways that include important mediators, the bradykinins, which is also involved in hereditary angioedema, and the prostaglandins, and also interfering with those pathways can either be helped can be used to help in the treatment of angioedema as well, because the same pathways are involved. Angioedema that is related to drugs that I've talked about, the ACE inhibitors in particular, can occur quite early within the first week or month of treatment, but can also occur quite late. And it's also very important to remember that drug-related angioedema can worsen patients who've got underlying hereditary angioedema. So everybody who's diagnosed with drug-related angioedema must also be screened for hereditary angioedema. And it also may coexist with hereditary angioedema. And patients with hereditary angioedema must also avoid these drugs because they work through the same pathway. So now let's now look at hereditary angioedema itself. It's caused by deficiency of the functional C1 inhibitor in most cases. It can lead to attacks of swelling that occur in any part of the body. Untreated, it lasts for about 7 to 14 days. Untreated patients have an attack on average every 7 to 14 days. And the prevalence on conservative estimates is 1 in 50,000 people, which means that we're missing a lot of patients in South Africa. So you can see the pathway here that C1 inhibitor is involved in, and it regulates or damps down every single aspect of this pathway. If there's less C1 inhibitor activity in the pathway, then this kallikrein is an important molecule that gets dysregulated, and that leads to lots of bradykinin that is produced. And bradykinin then causes the airway, the leakage of the vascular system and the swelling. And the reason that this is important is that kallikrein and bradykinin are now targets for some of the newer therapies. There are 3 different types of hereditary angioedema that we normally talk about. Type 1 is where there's a low amount of the C1 inhibitor itself. Type 2 is where the amounts of the C1 inhibitor are normal, but the protein is less active. So it's not got as much activity. And then what we used to refer to as type 3 is now called hereditary angioedema with normal C1 inhibitor. And it's not actually one condition. There are different conditions that have already been shown due to problems in factor 12, in angiopoietin, and in plasminogen, but there are doubtless others as well that have yet to be properly described and the mechanisms shown properly. Type 1 and type 2 are autosomal dominant, inherited. So that's passed on by usually one member of the family that's affected. But about 20 to 25% of people who have hereditary angioedema do not have any family members involved because it occurs for the very first time in themselves. But despite this, it's really important to make sure that whenever there's a diagnosis of hereditary angioedema, that all the family members are screened to check to see if anybody else is affected. So let's look at what actually happens in hereditary angioedema. Patients get attacks of swelling that are usually involving the face, the limbs, the gastrointestinal tract, the genitals, or the upper respiratory tract. There's no urticaria that is associated with hereditary angioedema, but there can be a prodrome which causes this tingling sensation, as well as a rash that is often called erythema marginatum. It looks a little bit different from urticaria, and it's not itchy, but some patients who see this rash might mistake it for urticaria, but it's not an urticarial rash. This prodrome that I spoke about is the tingling that can be seen or felt usually in the areas before the angioedema where it's about to occur. The swelling can be very severe and is very easily noticed. But the abdominal attacks, which are very common, are particularly important because they can't be seen and they only really become noticed when the swelling is very, very bad and the actual belly swells or it causes abdominal pain. So I always stress to my patients that abdominal attacks really, by the time you feel them, you're later on in the swelling, and they should be taken actually probably even more importantly than attacks that happen in your limbs, for example. Typically, the symptoms worsen over approximately 1 to 2 days and last for about 2 to 5 days before they resolve. So there's a wide variety in different people in terms of how long they last for though. The other important thing is that the typical age of onset is between about 5 and 11 years of age. People who present a little bit earlier might have more severe disease, but there's also a very, very wide range at which hereditary angioedema is has its first age of first onset. The triggers that we know that can cause actual attacks could be trauma, some of the medications or drugs that I've spoken about, particularly the ACE inhibitors and the non-steroidal anti-inflammatory drugs, and then puberty as well as changes in women according to their menstrual cycle. But attacks can also occur without any triggers, and the same trigger that in one occasion provokes an attack might not provoke an attack a second time, despite being very similar. So we spoke about when it first affects the patients, but despite the symptoms typically starting in childhood, most patients are diagnosed only as adults. And this really does point towards the fact that much more awareness of hereditary angioedema is required so that people make the diagnosis quicker. The diagnosis itself must be suspected when there are recurrent episodes of swelling, especially when those episodes have an early onset in somebody's life, when they're associated with those abdominal swellings that I've spoken about and abdominal pain. If there's a family history where there's no urticaria that is seen at the same time as the swelling and no response to antihistamines or steroids. And screening can be done with various blood tests. The blood tests that we normally do is a C4 level, and if the C4 level is low, we usually go on to check to see the level of C1 inhibitor, and in some parts of the world, you can do a C1 inhibitor function, and that can help you distinguish between type 1 and type 2 hereditary angioedema. The C1q level is used to look for patients who have the acquired form of angioedema, which I haven't really spoken about very much and don't really think we need to go into today. But you can see from this very much larger chart about all the, on the left-hand side, all of the different types of angioedema that I've spoken about so far, that you can sometimes make the diagnosis with those blood tests, but on other cases you need gene tests, particularly to make the diagnosis of hereditary angioedema with normal C1 inhibitor. And then finally, I'm going to touch a little bit on management, although this is Jonny's major brief to talk about the new advances in this, but I'm going to give a brief overview of the different types of management and treatments that are involved. And the first thing I want to point out is that the management of hereditary angioedema needs to be very multifaceted with attention to a lot of different areas, not just the medication. You need to look at the patient's quality of life, the costs, the disease course, the work and school issues, social changes, etc. In terms of really getting down to the nitty-gritty of the medication and educational aspects, we need to have treatments that are aimed for different times or different situations that the patient might be encountering. So the obvious thing is acute attacks. There needs to be medication to stop the swelling once they've occurred. But we also use medications for different types of preventative therapy, for short-term prophylaxis when the person is about to undergo a surgical procedure, or for long-term prophylaxis in people who are having relatively frequent or at risk of having severe episodes. But we also need to look at much more holistic things apart from medication. These include strategies to reduce the risk for the patient, including education, which should be aimed at patient empowerment. And what we find is that when our patients are well educated, they can take a huge amount of responsibility for their own care, and they often know much more about hereditary angioedema than the doctors that they'll come into contact with. In terms of acute management, within all parts of South Africa, the most widely available medication is fresh frozen plasma, which is still an effective treatment for hereditary angioedema for the acute attacks. But there are a lot of new treatments that are becoming available that you can see that have different targets within that cascade. And Jonny will be looking at some of these in a little bit more detail, particularly the ones that affect kallikrein and the ones that affect bradykinin. I'm not going to go through this table in any detail, but just to say that there are a number of different medications that can be used that are inhibitor replacement therapy. So these are usually given intravenously to replace the inhibitor that is missing. There are a couple of molecules that are widely available that are the small molecules or normal drugs that are used for long-term preventions, predominantly the androgens and the antifibrinolytics that many of our patients have been on for many years. And then there are some of these new targeted therapies that are aimed at kallikrein and bradykinin. But no matter which medication we use, we're going to be using them under different circumstances. And when you talk about emergency treatment, it's important to remember that the attacks must be treated as early as possible. So patients must be taught to recognize those prodromal symptoms and to be aware of both the upper airway signs that everybody worries about, but also be very, very aware of the abdominal symptoms, which, as I've said, can only really be felt by the patient when it's a little bit more advanced. And that patients with this must come in very quickly for emergency treatment, or if they've got treatment that can be given at home, to use that as soon as they have the first sign of attack. I've spoken about the short-term prophylaxis that is given just before a surgical procedure, including dental extractions. And there are lots of different treatments that can be used before a procedure in order to make sure that it's 100% safe for patients with hereditary angioedema. And then there's the large area of long-term prophylaxis. Hereditary angioedema attacks can reduce or minimize the burden of disease. There are older treatments such as the small molecules that I've spoken about, the androgens and antifibrinolytics, but there are also newer targeted therapies that are available for use as long-term prophylaxis. The newer developments in treatment also allow us to have early treatment with self-administration of patients at home. These on-demand medications require training of the person in order to make sure that they can recognize those attacks and use them very quickly, and they still should go and get emergency treatment even if the attack is resolving. But whatever interventions are available, they must be very clearly documented on an action plan. An emergency plan also requires lots of education and support. And what we aim to do is empower our patients so that they have self-awareness and self-responsibility and can really drive this for themselves and keep themselves and their families safe. So in summary, what I've kind of covered is some of the basics of hereditary angioedema being a relatively rare but underdiagnosed condition. There are two main types, the type 1 and type 2, but there are a third type which is actually containing multiple conditions under a larger kind of umbrella. Kallikrein and bradykinin are the most important mediators that are involved in the pathology of the disease, and it can be diagnosed with blood tests in most patients, but there's increased availability of gene testing. There are newer treatments available that address the actual pathway that is involved, but patients really must be given an action plan, a medical alert, or some other bracelets, and empowered to take responsibility for their own treatment. We must look at issues of prophylaxis for all patients in order to prevent attacks rather than just treat them when they come on. And we should also consider the increasing use of on-demand treatment. So that's it for me. And I'm going to hand over back to Janice, I guess. And or Jonny to start his presentation.
Thanks, Mike. Yes, I just wanted to say that we're gonna, if you have a question as you go along, we just can write it in the chat, and then we'll come to the questions all at the end, especially now that we are running a bit late. So yeah, Jonny, if you could start, that'd be great.
Yeah, thanks. Good evening, everyone. Thanks for inviting me to talk to you all, and thanks for also attending. Can you see my slide? Is that right?
Yeah, we can see it, Jonny. Thank you.
Excellent. So, Mike, yeah, thanks for a very good introduction. And I think you've also covered actually some of the slides that I've put in, so I can, speed through those just in the to keep to time. So, really, Mike showed you this layout, and this really puts the kind of on-demand or prophylactic treatments into some perspective in terms that where they work, right? The focus of what really causes the problem is this bradykinin. Bradykinin works through its bradykinin receptor on endothelium cells, which are inside of blood vessels, which control how fluid moves in and out of the tissues. And so that's why it's the critical factor there. And bradykinin is produced by kallikrein. So kallikrein is like an enzyme, and so basically inhibiting kallikrein is a good potential target. And then the C1 inhibitor, and where that fits in, is that actually helps to maintain a small amount of what's called the substrate, or the pre-kallikrein, and helps to not make the enzyme active. So it's a kind of upstream inhibitor. And C1 is made by the liver. And that's why androgens, what they do is they actually increase, even if it's a non-functioning C1, or there's a very low level of protein, it will push that up, and that's how it works. Our plasma products help to just replace that, right? So Mike showed you that you're actually just giving people in the acute situation C1 inhibitor. And then tranexamic acid is a little bit more difficult in terms of understanding, but it works predominantly on this system in relationship to factor 12. And factor 12 has a positive effect on this pre-kallikrein molecule. And that's thought to be the way that tranexamic acid works. The important part is that we now have a lovely set of drugs that can inhibit these molecules. And some of them in the context of South Africa and the context of your care is really what I'm going to focus on talking about. But I think it's worth looking at this. We published this timeline some years back, because the things to look here is just to actually look at some of the years. So, it was only really in the 1960s that tranexamic acid was first used for HAE, and in the 70s, androgens and fresh frozen plasma for acute attacks. And then there was this quite long period of time where, apart from Berinert, which is a plasma-derived C1 inhibitor, there was really not a lot of development. And then in the last 2 decades, internationally, there's really been a lot of activity in terms of pharmaceuticals and targeted molecules for the treatment of hereditary angioedema. So it's actually really an exciting time internationally for treating and looking after this disease better. And just what we did is, this is the kind of international arena where these drugs have been registered by different regulatory bodies in terms of timing. But in the bottom here, I put some outlines of the South African process. And I mean, there's a couple of things that are, really worth noting. The first is Paul Potter, Sheila, and I've talked about this before, Sheila Baker. They really did a lot to also help get access for patients. And I was actually commenting today, we have 2 patients, in our HAE South Africa family that are still receiving icatibant from post-trial access from this FAST-2 trial, which is one of the original registration trials for icatibant. And this is now 16 years on from that trial. So it really is a kind of amazing aspect that potentially through trial access, you can get access to these life-saving medications. But fortunately, things have moved on quite a lot. And again, I want to acknowledge this society, this organization, for its role in liaising with HAE International, in really advocating for these treatments, because it's through your involvement with HAE International that really some of these relationships, particularly around the Global Access Program for Ruconest, was established. And more recently, we've also got colleagues from Takeda on the call through their interactions as well with all of us, that we are now starting to see an access icatibant treatment as well. So this, Mike has gone into more detail about the sort of treatment, but this really is our treatment landscape. From the perspective of acute treatments, most of you here and other people in different parts of South Africa, especially more remote areas outside of big urban centers, will be still receiving fresh or even freeze-dried. We've had some success with using freeze-dried plasma, and that really gives you somebody else's C1 inhibitor. That's exactly how that is working. Then there are, we now have access through this global access program to a recombinant C1, and there's also people that have accessed the plasma C1 inhibitor, which is called Berinert, which is made by CSL Behring. And icatibant, I'm going to talk a little bit more about. The main differences here is the first 2 treatments I've been talking about were intravenous treatments, and the last one, icatibant, is a subcutaneous injection. So those are really the acute available treatments. Then for short and long-term, particularly long-term prophylaxis, the majority of patients in our South African context are still accessing attenuated androgens. Children are often accessing tranexamic acid, and some adults. And tranexamic acid seems to work particularly more for HAE type 3. And then we've also been fortunate enough to be part of the development program for the oral kallikrein inhibitor, which is now marketed as petrelostat, Orlandia, which is, and it's registered with the FDA and sold in America. And we have several patients accessing that drug still, probably some of you on this call, accessing this drug through a prolonged, it's now into a very long-term extension study. This is really some of the things about attenuated androgens. So there's a lot of, especially in the international literature there, and the kind of talks in the groups, there's quite a lot of negative press about attenuated androgens. And actually, we have our experience in South Africa with about 50% of patients in our cohorts on Danagen. They can use quite a low dose. Some patients are only just on 100 milligrams. And for the majority of patients, that is actually very well tolerated without major long-term problems. And you can see here the control we get is around 70%, and this actually is around the same figure as we're seeing with petrelostat. We don't have any adults here on tranexamic acid. Mike's already mentioned the need for these cards to know. Some of the side effects that people worry about that we do see with particularly attenuated androgens is these mood alterations or insomnia. We see hirsutism and acne. So it's really a problem, especially in female patients, the problem of male androgens that are problematic. There's also metabolic changes that occur, and a very rare complication of hepatic adenomas. Some of you may have had liver functions or ultrasounds, and that would be the reason that we were looking for. The real development in terms of accessing kind of targeted and specialized medicine has been in the acute care phase. So this is fresh frozen plasma for those of you that may be familiar with this or have seen it. And then these are the vials. This is the vial of Ruconest, which is the recombinant C1 inhibitor. This is given as an IV preparation. It's mixed with sterile water. You get it up into this. You can see here's like a 10 ml syringe, and it's given intravenously over 5 minutes. This is icatibant. You can see here it comes as a pre-filled syringe, and it's injected again slowly subcutaneously. So both these treatments, interestingly now, can be given at home. So in many parts of the world, Ruconest, it's the farming company is making it with like a little kit for home administration. So if people are adequately trained, people are using intravenous medications at home. But for the most part, in South Africa, these IV medicines are still given in the emergency room setting, even if it's taken by the patient to the emergency setting. Icatibant is a subcutaneous injection that can be given at home. And of course, fresh frozen plasma needs to be given intravenously at an emergency center. So we now actually, together with an Iranian cohort, we've published this paper, which is the largest cohort of using fresh frozen plasma for acute attacks. And again, in some of the, if you speak to some HAE International colleagues, certainly they've mentioned this to me prior to publishing this paper, was that people were concerned about worsening of attacks with fresh frozen plasma. We actually haven't seen that. In this big cohort here, we saw that there was no worsening, and in fact, most patients did get better. The major problem was the time taken to get better. So you can see here, it took on average 4 hours to start having some resolution of symptoms. So that often meant that people, and many of you will have experienced this on this call, that they actually require admission to hospital, overnight stays. Whereas some of the targeted acute medicines, their effect is actually maximal by usually an hour. And that can often avoid hospitalization altogether or really limit the stay. The transfusion reactions, again, from fresh frozen plasma are not too bad. We have had some cases of mostly urticaria, and in 1 or 2 instances, anaphylaxis that's been more severe. So there is this risk. They have also, this is very similar to a lot of other blood products. And of course, the precedingly blood products have been a concern for infectious disease transmission, but the systems of viral inactivation of looking after our blood products have become better and better over the last couple of decades. And really the risk of any kind of infectious transmission from blood products is now extremely low. Just here, there's a comparison between the fresh frozen plasma and the icatibant. You can see here the way you give it is different, but the main thing I would highlight is this time to onset, and that's really the big advantage of acute targeted therapies. And also the main thing is, as a result, there's downstream implications. So, Mike mentioned abdominal attacks. Abdominal attacks, the sooner you treat them, the more likely they can be to be stopped. And so oftentimes these acute treatments can avoid an admission altogether. This is some examples of the Global Access Program for Ruconest. So we were doing very well with this. We had both private sector patients, we've had state patients at our Karyotype clinics accessing this vials, and we were given 2 free vials from the company. Some of you may in fact have some of these vials still. And this was certainly the first targeted therapy that I got approved in the public sector for South African patients. The current issues that we are having relate to mainly couriers and actually getting it. So I'm going to highlight this one point around these targeted therapies. Please, and this is a request to all of you, we've been trying to take care of the administration of these treatments increasingly. Please do not wait until these treatments are used up before initiating the need to get more. So please, and this is actually especially true for people that are not on any kind of long-term prophylaxis, especially people that actually have very few attacks. Attacks can come suddenly out of the blue, and the key thing is you really want to be prepared, even if it's just the off chance. You want to have taken that preparation. And so, sometimes we don't have stock of these things because it is a considerable admin burden still to get all these things sorted out. And sometimes it also takes time. So if you've used up your 2 vials, you've used up your icatibant, then it can actually take some time to get a replacement. So please make think about this in advance. Then in terms of icatibant access, so icatibant has come off patent. And of course, for those of you that don't know, the icatibant was developed by a company called Shire, which was then acquired by Takeda. So Takeda now has the access to icatibant. They have submitted a dossier with our local South African regulatory body. And so hopefully they'll soon see icatibant registration in the coming months. It's currently, though, on an early access basis. So it's currently is being accessed and is available. Its price has come down dramatically over the last while, and it's, I think, at a very good price point at 7,000 Rand a dose. There's 2 patients I mentioned still accessing it through the post-trial process. And we now have access certainly at our Hereditary clinic and at Red Cross. And if you now come to our emergency room at Hereditary and you present there with acute attack, we were able to access either Ruconest or icatibant to treat people acutely. And where patients have got access to icatibant, we're also giving them to obviously use it at home. And this is especially useful for patients that are more remote and further out from emergency cares. So that's a very exciting development. Betrolstat, I mentioned, we have been involved, and we were involved in the early trials, and this has now moved right across to a long-term follow-up trial, which is a sort of very hands-off trial where people are using the drug and just report to our site for follow-up every 6 months. There's very little requirements. We've now got 12 patients still on this long-term follow-up study. And potentially, this, at the moment, the agreement is that these patients will stay on the study until the drug was registered in the country. That's normally how post-trial access works. And so this is potentially a long time that they may have access to this drug. There's also a competitor product made by another company that's now into phase 3 studies, and we should be commencing that work as well. So we're going to be working with that product for those of you that are interested too. And that's a very similar oral kallikrein inhibitor. And that's really my take-home points. I'll end there. The first is just to say, look, we are increasing. So, you know, a lot of you will still be accessing fresh and freeze-dose plasma for acute events and long and attenuated androgens, but there are now these acute treatments that we are having available and accessing. And so our center is trying to set up, and you'll hear more about it over the while, we're trying to set up a virtual angioedema center, which you can consult from across the continent and even remotely. And then also we now have dedicated admin help, where we're going to try and ensure that people's medical aids approvals or the required state sector section 21s or whatever is required to help people access the courier costs from overseas, or all these things. So please make sure that you connect with us and our center for accessing and trying to access this for your care. Access remains an issue for lots of the other things. So sometimes when somebody has difficult side effects or you know, some of these treatments are not working as we want them to work, then we still have other options that I haven't even talked about. So people are accessing subcutaneous C1 inhibitors. People are accessing a monthly monoclonal for inhibiting kallikrein, but these are very expensive therapies, and access is still a problem. And so we're still exploring that. So I'm in contact with most companies. I've been asking people for compassionate use for certain patients. And so we really need continued active advocacy from a group like this to ensure that some of those treatments definitely filter down. And I mentioned this about the need to plan for future attacks. So this is our center, and once again, acknowledging all of you there. And then the last thing, just to put out, most of you probably have this hotline number, but we've launched this initiative of the angioedema hotline, really to try and care for angioedema patients that are in more remote centers around the country. And hopefully through awareness, advocacy, talking, we can actually make more diagnoses, because there are still provinces in this country which should and almost certainly have cases of hereditary angioedema that we don't have and we don't know about. So the more kind of advocacy and awareness we do and availability of this kind of initiative, I think we should improve the diagnosis of this condition and hence the treatment across the country. Thanks very much.
Thanks, Jonny. That's great. There are a couple of questions, which is good. We're going to come back to those after Marianne, and then yeah, just so that we don't get all sucked into that. Okay, no worries. So Marianne, you can.
Okay, just give it a second to tick over. Can you at least see the slides if it's not on full screen?
I can see it perfectly.
There we go. Okay. So hi everyone. First of all, I want to say thanks so much for having me speak to you guys today. My name is Marianne, and I'm now working for Rare Disease South Africa, which Jenna said earlier. And what I really want to do today is give you a little bit of information on genetics and genetic counseling specifically. So it's really going to be sort of a crash course in genetics. So bear with me, we're going to go slowly. Okay, so DNA, genes, and chromosomes, these are words that we obviously bandy around very often, but what do they mean? Like what are we talking about when we talk about DNA and genes and chromosomes? So I like this little infographic because it really kind of puts it in a little nutshell. So we know that our body's made up of cells. We've got millions and millions of cells, and we've got skin cells, hair cells, etc. And in each cell is the nucleus, which is almost like the powerhouse, the driver of the cell. And within the nucleus, we find our DNA. And really what our DNA is, it's almost like an instruction manual for the body, telling our bodies what to do, how we must grow, what we must look like. And this DNA is packaged into these structures called chromosomes. So if we were to take a chromosome and unravel it, we can then go in and we can see that lovely DNA double helix that we've all seen pictures of. And certain sections of the DNA are the genes, and the genes are the actual instructions that are telling our bodies what to do. So there are over 20,000 different genes, all having different functions within the body and all on the different chromosomes. So now if I was to take blood from you or from me and we look at one cell under the microscope, we can look at the DNA in one cell of the body. And this is what it would look like. We call it a karyotype. So believe it or not, this is the DNA in one cell of your body. So you can see all the little chromosomes, and you can see that they're arranged in pairs. So we have 2 number 1s, 2 number 2s, 2 number 3s, etc., etc. So we get one from mom and one from dad. So we literally are half our mother and half our father. So that's why they're in pairs, one from mom, one from dad. All these chromosomes up to number 22 are called the autosomes. And then I want to highlight these two at the end, which are the X and the Y. So these are the sex chromosomes. And if you're XX, you are biologically female. And if you're XY, you are biologically male. So the key take home here is that you have 46 chromosomes in every cell of the body. And on these chromosomes are the genes telling our bodies what to do. So here's our summary. 22 pairs of autosomes, the X and the Y, which is the sex chromosomes, 46 in total. So this will all become important when we explain how conditions get inherited and how you get your 23 from mom and your 23 from dad, which we're going to talk about now. So let's talk a little bit about inheritance of our chromosomes. So we know, I've just told you that you have to have 46 chromosomes in every cell of the body in order for the body to work properly. So 46 in mom, 46 in dad. So what happens if we each give 46 to the babe or to our baby? Then obviously they're going to be too many, and that's going to cause problems. So in the egg, it's a natural process that happens. 23 chromosomes go in, so one from each pair. And the same process happens in the sperm in males. So that when the egg and the sperm come together and a fertilization happens, then we get a zygote with 46 chromosomes, and we have our baby. So there are lots of different genetic conditions that can happen when something goes wrong, either with the chromosomes or with a single gene, or then they're more complicated sort of genetic conditions. So sometimes you can have too many chromosomes, and this is the case with Down syndrome, where we know these the children with Down syndrome or individuals with Down syndrome have an extra chromosome 21 in every cell of their body. Then if we look at something like a single gene, so a mutation happens in a gene, which happens on one of those autosomes, one of those number 1 to 22, and two of the genes, both copies of the gene, the one from mom and the one from dad aren't working, you get something like albinism. And then you can also have what we call multifactorial conditions, where it's caused by a mix of genes and environmental factors. So genetic conditions there are a lot of them, and they can be caused by different things. So either by the gene or the chromosome or a rearrangement, lots of different reasons. But the one we want to look at now is we want to look at this autosomal dominant, because that's what hereditary angioedema is. It's an autosomal dominant condition. Okay. So here's our karyotype again. And the gene that we're looking at predominantly with hereditary angioedema, which both profs have spoken about earlier, particularly Prof Levin, is there's a particular gene on chromosome 11, which when mutated accounts for majority of the cases of hereditary angioedema. And that's called the SERPING1 gene on chromosome 11. So if you have HAE, one of your copies isn't working properly. So how does that translate to how we inherit this mutation? So we know, and was mentioned earlier again, that in about 25% of cases, this mutation happens for the first time in an individual. But in the majority of cases, it's being inherited through a family. So let's say, for instance, dad has HAE and their mom doesn't have HAE. So there his 2 copies of chromosome 11, one has the mutation. So because he's got that one mutation, that gene can't work properly. Mom has her 2 copies of chromosome 11 and they're both her copies of that gene are working. So there's a 50% chance with every sperm that is created, that is made, that chromosome 11 with the mutation will go into the sperm. Mom will always give a chromosome 11 in the egg that doesn't have a mutation because she doesn't have HAE. And together, they come together to make the baby who will have HAE. Yeah, so with every pregnancy that this couple has, whether dad has the condition or mom has the condition, there's that 50% chance. So that's where the 50% comes from. Okay, so what does this all mean? How is this relevant to genetic counselling and to genetic counsellors? So I think let's have a little discussion about what is a genetic counsellor, because I know for the most part, most people have never heard of genetic counselling and they're not sure what going to see a genetic counsellor would entail. So I often get asked this question, what work do you do? And I'm like, well, I'm a genetic counsellor, which to be honest is usually a conversation killer. A what? And this is across the board, I get this answer. So they say, oh, you're a psychologist. You must be a counsellor, so you must be a psychologist. I'm like, no. And they're like, you must be a doctor. I'm like, no, not a doctor. Oh, then you work in a lab. And I'm like, no, definitely not. So what is genetic counselling? I love this infographic because it really sums up nicely the sort of the 3 components of genetic counselling. So it's a bit of medicine with a bit of science and a bit of communication. So a lot of the work that we're involved with obviously is the different conditions and what they mean and how they're diagnosed. Not that we do the diagnosing, but that we have to explain it to people. So we need to know about the specific conditions. That's where the medicine comes in. The science part comes in when we need to analyze lab results. We need to know what's going on at the molecular level to the genes and the pathways that are involved. But the key component is the communication. So we're the ones who are there to explain things in a logical and an understandable manner so that people can come out the session and be empowered with the knowledge that they need to make some informed decisions. Genetic counselling is a fairly new profession. The first graduate program was established in America in 1969. And in South Africa, Wits University was the first to establish their program, which is a Master of Science in Medicine and Genetic Counselling in 1989, followed on by UCT. So they're really only Wits and UCT that offer the Master's program in Genetic Counselling in South Africa. So what is genetic counselling? This definition was created in 2006, and it really sort of sums up what we do. So genetic counselling is the process of helping people understand and adapt to the medical, psychological, and familial implications of the genetic contributions to disease. I put this in because I think it's quite nice to know that we don't just see a wide variety of patients. So somebody may come in with a family history of a condition, which would be very pertinent to someone who's been diagnosed with HAE or has a family history of HAE. But we also see individuals who have a child with a birth defect or developmental delay, individuals who come in who consanguinity basically means that individuals who are related to each other, so first cousins or second cousins, because they're at increased risk for certain conditions. Someone who's over 35 years old and is planning a pregnancy, we call that advanced maternal age, and they're at increased risk for certain genetic conditions. We also see someone who's had multiple miscarriages, because 3 or more multiple miscarriages may indicate that there's something genetic happening. Also, if there are abnormalities on fetal ultrasound on the fetus. if someone was exposed to some kind of teratogen or like medicine or something that would be detrimental to their developing baby. And lastly, if someone was from a high-risk ethnic group. So we know that certain groups, particularly in South Africa, are at an increased risk for genetic conditions. So like the Ashkenazi Jewish population and the Afrikaner population. So we know we see a lot of individuals from those groups who come for genetic testing. So what happens in a session? I also get this asked quite a lot, and I think this will kind of maybe give you a better idea of what we do and how we do it. So first of all, in the session, we try and establish your reason for coming to the session. Like, do you have a family history of a condition? Have you been diagnosed with a genetic condition? Do you have a pregnancy with an abnormality discovered on ultrasound? Is there something bothering you? Were you just told to come? So very often the reason that we think someone's there is not the reason that they're actually there. So it's really important to establish the reason for coming to the genetic consultation. And then we take a very thorough family history, at least 3 generations. And then we ask lots and lots of questions like about any significant medical diagnoses, any family members with conditions, even maybe something you hadn't even thought about that could be, we know is linked to certain genetic conditions, but you might not necessarily. Any history of cancer or intellectual disabilities and those kind of things. And that follows on, then we will obviously have a discussion on genes and chromosomes and how things are inherited. And then we would delve into genetic testing, if there's genetic testing that's available for the particular condition, look at the pros and cons, the limitations, because there's limitations to every genetic test. As was stated earlier, there are over 500 different mutations that we know about in this SERPIN-G1 gene that is the cause of the majority of cases of HAE, but not all of them. So there's a lot that we still don't know, especially in terms of genetics. So I think that people need to be aware of that when they're choosing genetic testing. It's not always a yes/no answer. Treatment options, if they're available. We also discuss prevention and management things that need to be put in place, the options if test results are positive. And then most importantly, we're there to provide emotional support and to offer resources and more information and to refer to psychologists or support groups or someone else if we think that's relevant. So we really are aiming to encourage informed decision-making through the appropriate discussion of medical information. I think that's sometimes the trickiest part, is identifying what's the most appropriate. So we don't want to overwhelm you with too much information, but you also need to have enough information to make an informed decision, with a focus on the psychological well-being and addressing any fears, hopes, defenses in order to help you make sense of your situation. And then, of course, the prevention and management of birth defects and genetic disorders. Obviously, everyone is unique and individual, and everyone makes different choices. So we're there to help you with your choice. We're not there to tell you what to do. So again, genetic counselling aims to empower an individual. So always in a non-directive manner, as much as one can be non-directive, with the knowledge you need to make an informed choice about your health or your child's health, remembering that no 2 people will make the same choice. So in closing, I found this wonderful excerpt from a paper that was paraphrased from a French geneticist at a conference. And it says, a genetic counsellor is like air conditioning. When you do not have it, you do not realize you are missing it. But when you have it, you cannot live without it. So this is where you can find me at Rare Diseases. I started in February. We now have, under resources, we have a particular tab, link for genetic counselling. So there's some information there, and then there's a sign up page. So I encourage you, if you think you might benefit from having genetic counselling, then please do get in touch via the Rare Diseases website. Thank you.
Thank you very much, Marianne.